Good evening to one and all. On behalf of Dr. Agarwal's Institute of Optometry, I extend a warm welcome to each and every one of you. Today we are here with episode 8 of Optometry series. The topic for today is interpretation of fundus fluorescent angiography. I'm very happy to extend welcome to our dearest moderator, Ms. Ramya ma'am. Hi ma'am. I'm also very happy to welcome our HOD of Research and Innovations, Ms. Maheshwari ma'am. Hi ma'am.
Hello.
Hi ma'am.
Hello. Thank you, Gomati. Actually, I met Ramya in Shankara Netralaya when I went as an examiner. So I was seeing her in-depth knowledge in the posterior segment, the kind of practical knowledge that she has. So I was so impressed and I wanted to invite her in any of the sessions with us. So she sees the patients day in and day out, and she sees a lot of patients, and it comes very easily to recording the diagnosis and how she interprets the results and all. It was really amazing. So, over to MC, who's doing it?
Yes,
Okay. So for the formal introduction and formal invitation, I will leave it to you people. Thank you.
Thank you for the introduction.
I request Ms. Anjana to welcome our guest today. Hi, Anjana.
நீங்க மியூட்ல இருக்கீங்கப்பா அஞ்சனா.
Thank you, ma'am. Okay, thank you, ma'am. Good afternoon. Can I start? Okay. It's my great honor
Please, you can start. Your voice is not clear.
Good afternoon, ma'am. It's my great honor and pleasure to introduce Miss Ramya S. She is working as a working as a senior optometrist at Shankara Netralaya Medical Research Foundation, Chennai, and associate professor at Elite School of Optometry, Chennai. She has completed her undergraduate and postgraduate degrees at Elite School of Optometry, affiliated to BITS, Pilani, Rajasthan. As an optometrist, she has a clinical experience of about 40 years in diagnostic techniques, such as ocular electrophysiology and optical coherence tomography, and had seen more than 10,000 patients apart from routine optometric examination. She has years experience in low vision care clinic. She has about 12 years of teaching experience and handled various courses such as ocular disease, low vision care, and research methodology, optometric instrumentation, ocular anatomy and physiology, geriatric optometry, and few optics-related topics for undergraduate and postgraduate optometry students. She is also part of book chapters and had given guest lectures in field of ocular electrodiagnostics. She is also guides undergraduate and postgraduate students in various projects apart from training optometrists in electrodiagnostic clinics. She has published around 10 articles in national and international journals. It is such as an honor for us to have you today with us, the speaker. For today's section is Miss Punitha, who is doing second year at the Agarwal Institute of Optometry. Now I request Miss Punitha to start the presentation.
So that's amazing that you have seen more than 10,000 patients. So happy to have you here with us.
Thank you, ma'am. Thank you.
Yeah, you can start, Punitha.
Yeah, very good evening. Thank you for the introduction, Ms. Sanjana. Okay. Okay. Today we are going to discuss about FFA. Okay. What is FFA? It is nothing but fundus fluorescent angiography. We all know that fundus. Fundus is nothing but where we appreciate the optics, the blood vessels like arteries and veins, the macula, fovea, everything. And coming to fluorescent. Fluorescent is an dye that will be using in this procedure to evaluate the retina and the choroid. Then comes the angiography. Here, you need to click pictures for the results. Okay. Then, what is fundus fluorescent angiography? It is an invasive diagnostic tool for the evaluation of the retinal and choroidal vessels. It allows the sequential visualization of the blood flow simultaneously to the retina and the choroidal as we inject the fluorescent dye via veins of the patient. Then the photography. The photography will be performed by using the fundus camera or either by using the video-based systems. Then, what is fluorescent? Fluorescent is nothing but, it is also referred as fluorescent sodium. It is an orange-red crystalline substances with a highly water-soluble, and this fluorescent is available in as a tropical solution, strips, and as a injections, like in a solution form. Next. Coming to principle. So the principle is totally dependent upon the substance of the fluorescent. So, okay, what does the fluorescent will do? Fluorescent will absorb the light energy from a lower wavelength and emits at a higher wavelength That is, it has an absorption spectrum of fluorescent lies between 465 nanometer and 490 nanometer, which can be seen at the blue end of the visible spectrum. And the emission spectrum lies between a 520 and 530 nanometer, which we see between the green and yellow area of the spectrum. Next, how does the principle works? Basically, the white light will passes through the blue excitation filter. This will allows only the blue light to pass into the retina. As it gets passed into the retina, it has to reflect. So while reflecting, both the blue rays and the white light, and the yellow light will come simultaneously and face the yellow-green barrier filter of 530 nanometer. This will cut the blue rays and emit only the yellow rays into the camera, like where we can see the end result of the FFA picture. Then comes the technique. Okay, while before proceeding the technique, we need to explain the procedure to the patient and need to get a consent form from the patient. So for a good quality images, we need to first properly dilate the patient by using Moderator S. Next, after dilatation process, we have to make the patient to sit comfortably in before the camera and make the patient to face the camera. And after these procedures, we have to inject the normal saline into the patient's peripheral vein to check the patency of the blood circulations. So after checking the patency, now we have to inject the fluorescent dye into the peripheral vein of the patient. But basically, we'll be performing this test in the left hand because so that it will easily connect to the heart and the eye. Next. As soon as we just injected the fluorescent, we need to switch on the timer, and the images should be taken at 1 to 2 seconds at interval to capture the early phase. Then coming to the that late phase, at the end, we have to check for 10 to 20 minutes to click the photos. Okay, as we inject the fluorescent dye, the 80%, that is 70 to 85% of the serum, that is fluorescent, will bind with the serum proteins, and the remaining 20% will unbound at the flow of the blood circulation. And this dye will be get excreted at the kidney within 24 hours. And we have to monitor the heart rate during this procedure.
Okay, Punitha. And to make the session more interactive, let's have few questions in between. The YouTube participant and the Zoom participant try to answer in the chat box. So the first question is from the principal. Tell us from the barrier filter which light passes by and which light is blocked.
So you can put the answers
Yes,
in the
continue,
chat
Punitha.
box. Mhm.
Yeah, we can see the answers in the chat box, so kindly put it in the chat box. Yes, Punitha, continue.
Yeah. Then what are the contraindications? So we can't straight away make a patient to undergo FFA procedure. There are certain contraindications, like if a patient have the history of fluorescent allergy, they have to treat it with anti-allergy. After that, we can proceed the FFA. And in renal failure patient, we can use the low fluorescent dose. And in pregnant women and a patient with moderate to severe asthma and other significant cardiac diseases. Then phases of angiogram. The first phase is choroidal phase or pre-arterial phase. Phase 2, arterial phase. Phase 3, arteriovenous phase or capillary phase. Phase 4, venous phase. Phase 5, late phase or recirculation phase.
Yeah, question number 2. Tell us how many seconds that the dye takes to reach the retina. Participants, please answer in the chat box. Yes, Punitha, continue.
Okay. Before going to see about the phases of FFA, we have to know the normal fluorescent angiogram. So it takes 10 to 12 seconds to reach the retina. We all know that if the blood circulation in the eye that should involve the ophthalmic artery, where it involves the posterior ciliary artery for the choroid and central retinal artery for the retina. So we can have a doubt like why these fluorescent dye won't get diffused out of these blood vessels. That is basically is because of our blood retinal barrier. Our blood retinal barrier is of two types: inner blood retinal barrier and outer blood retinal barrier. So while saying about the inner blood retinal barrier, it is formed by the tight junctions of the endothelium. So it won't let the dye to get diffused out. As well as in outer blood retinal barrier, there is a pigment called retinal pigment epithelium. These will keep the fluorescent from diffusing into the vitreous cavity or subretinal phase. Then the pigmented retinal epithelium will mask the choroidal fluorescent during the fluorescent angiography. Next, coming to our first phase, which is nothing but your choroidal phase. This can also known as pre-arterial phase. This will take 1 to 2 seconds after it reaches the central retinal artery. In this phase, we can see the patchy filling of the choroid. As these fillings will won't get diffused out due to the presence of the this will diffuse due to presence of the choriocapillaries. Then there is a serioretinal artery. If it is present in this time, this will derive from the posterior serous circulation. And then comes your arterial phase, in which the dye as soon as enters the retinal arterioles is known as arterial phase, and this will start about a second after the onset of the choroidal fluorescent. Then the arteriovenous phase. This is also referred as capillary phase, in which the dyes will enter the venule passing through it enters the venule after passing through the retinal capillaries. When we look for the early arteriovenous phase, this will show the laminar flow, as these dyes will pass through the blood wall of the blood vessel. In the late arteriovenous phase, the veins are filled with the dye. Then comes the venous phase. In this phase, the angiogram will show the loss of laminar flow and complete filling of the veins. In this phase, the veins appear brighter than the arterioles, as the concentration of the intensity is more than the venules than the arteries. The peripheral capillary filling will be reached around 20 to 25 seconds. Then our last phase, which is nothing but a late phase or recirculation phase. In this phase, we can see the elimination of the dye, and the fluorescent within the retinal vessel will be faint, and this will appear as a stain. Then the scleral staining appears as a diffuse background fluorescent. We can ask why the fovea appears dark in FFA. As we all know that there is no blood vessels in the fovea. This is the one main reason the fovea appears dark, and the presence of high density of the xanthophyll pigment at the fovea, which will block the fluorescence, and the presence of RPE cells, which are large in content and they are more tall. So the melanin and lipofuscin pigments are much in number, and thereby it blocks the fluorescence.
Okay, moving on to question number 3. Why dye appears in cilioretinal artery in choroidal phase? Try to answer in the chat box.
Yeah, there are some answers in the chat box, and
Yeah,
there is some question on.
questions we'll discuss in the last, ma'am. Punitha, continue, Punitha.
Yeah, ma'am. Okay, coming to the abnormal angiogram. Still now we just learn about what is normal angiogram, fluorescent angiogram. Now we're learning about the abnormalities of the angiogram. This is basically classified into two types, which is nothing but hyperfluorescent and hyperfluorescent. By the name, we can able to catch it up. What is hyper and what is hyper? Which is nothing but, if we come to see about hyperfluorescent, it is the reduction of the fluorescent or the absence of fluorescent. And hyperfluorescent, where the intensity of the fluorescent will be seen higher due to some retinal problems, like vascular problems in the retina.
Question number 4. Yes, we'll do see about the interpretation part, but before that, can you try identifying any condition that causes hypofluorescence or hyperfluorescence in retina? Guess the answers, at least 1 or 2 conditions for hypo and hyper. Continue, Punitha.
Yeah. Okay, as I said before, the reduction or absence of normal fluorescence will be termed as hyperfluorescence. So this can be caused by blocked fluorescence or hyperperfusion, which is nothing but the vascular filling defect. Okay, blocked fluorescence, like blood pigment exudates, will block the underlying fluorescence. Area of blocked fluorescence will be correspond to the area of abrasion. As we look into the picture, the pre-retinal hemorrhages can be seen in the normal fundus. And if you look for the FFA picture, there we can find the hypofluorescence due to block. Then comes the vascular filling defect, which is nothing but the vascular will not filled with the fluorescent. So hyperfluorescent due to non-filling of the vasculature due to vascular occlusion or loss of vascular blood. Coming to hyperfluorescent. As I said before, when the intensity of the fluorescent or the circulation of the fluorescent is being like more prominent, we can say as hyperfluorescent. So this can be seen in transmitter fluorescence, which is nothing but when there is a loss of RPE barrier and in leakage of blood vessels, cooling, and staining. Then coming to window defect, just nothing but it is a hyperfluorescent spot that appears in the choroidal phase. It may appear due to the increasing in intensity as progression of the angiogram, and it gets fades in the late phase and emptying the choroidal vessels. The size of the lesion remains same and there may be no fuzzy margins. Now, coming to the principles of angiography interpretation. How we can interpret it as whether it is a hyperfluorescent or hyperfluorescent based on the causes. First, as I discussed before, hyperfluorescence is caused by blocked fluorescence and a vascular filling defect. Okay, in blocked fluorescence, like hemorrhages, exudates, glial tissue, retinal pigment shows the hyperfluorescence, and in vascular filling defects, the emboli, arteriosclerosis, vascular non-perfusion, and vascular occlusion. Now we're seeing about hyperfluorescent. Hyperfluorescent will be seen because of the abnormal vessels, like whether the vessels seem to be tortuosity or get dilated, or if there is any neovascularization, aneurysms, subretinal neovascularizations, and leakage. Leakage may occurs in papilledema, cystoid edema, or occurs due to subretinal neovascularization or retinal neovascularization. Okay, yes, here are a few examples about hyperfluorescence. In ischemic diabetic maculopathy, due to non-perfusion of the capillary in the central macula is shown in the first picture. And the second one, we can see the extensive hyperfluorescence due to capillary non-perfusion. And third is, it shows the extensive hyperfluorescence by the capillary non-perfusion with the mid-perivascular hyperfluorescence. Then coming to retinal arterial occlusion, this is how the FFA will be look. Then comes to hyperfluorescence. In the hyperfluorescence, we can see in diabetic retinopathy, as the spots in the first picture, we can identify the scattered hyperfluorescent spots that occurs due to microaneurysms. Then the second picture, same, but it shows the central diffuse hyperfluorescence with a flower metal configuration. And third picture shows leakage corresponding to the center of the exudate ring. Then in proliferative retinopathy, the leaking disc vessel with extensive peripheral capillary dropout and small focus of bleeding vessels elsewhere. And branch retinal vascular occlusion, we can see the hyperfluorescence. It is much more prominent than the retinal arterial occlusion. Then comes the macular ischemia. Mostly this hyperfluorescence will be seen in the ischemic conditions. And proliferative sickle cell retinopathy, the staining and pooling is shown as a hyperfluorescence that occurs due to capillary non-perfusion.
Okay, I guess the question is repeated actually. So instead of this, can you tell us why microaneurysms will cause hyperfluorescence? Continue, Punitha.
Okay. If we take any procedure or any technique or any test, we'll be discussing about its advantages and disadvantages. Okay. Now we can see about its advantages, and it is a protective procedure and it causes infection very rarely, and it will allows us to assess both the anatomy and the function of the retina and the choroidal vasculature, and it has become a vital component for the diagnosis, treatment, and management of the vitreoretinal disorders. And it will give the defined location of the pathological changes, such as which is seen in choroidal neovascular membranes, and treatment can be initiated as the pathologic conditions is seen before, and the unaffected areas can be preserved. and its limitation. If we see about its limitation, its major limitation is it doesn't give precise image of the choroidal circulation, and it involves more technical procedures requirement, like we need photographic equipment, as well as in addition for that we need to have a trained photographer for a good quality results. Next, we cannot quantify the macular edema in this FFA. Like if you take diffuse diabetic macular edema or uveitic macular edema. And these are my references. Thank you.
Thank you so much, Punitha, and thank you so much, Meenakshi. I request our moderator, Ms. Ramya ma'am, to share her valuable points. I request the audiences to post your questions in the YouTube chat box, as well as in Zoom participants to post your questions in the Zoom. We'll have a separate question and answer session at the end of the today's session, so that the audiences, YouTube audiences, are also getting to know the questions that have been asked by the Zoom participants. Hi, ma'am.
Yeah, that's a very good presentation. And you have extensively covered all the abnormal findings. So, Punitha, can you answer me what is the common
Yes, sir.
side effect of fundus fluorescein angiography?
It will cause nausea, vomiting, headache. Next, the patient will feel like you are not in a normal state.
Actually, the commonest side effect will be a discoloration of urine. So the person who's taking the procedure has to inform them that at least 1 or 2 days they'll have a yellow colored urine. And nausea, vomiting, as you told, will be present at least in 30% of the patients. So that is why they advise that they should not take any solid food at least 2 hours before the examination. So as you told, other things are there. And if a patient is having a renal failure, then we also have another modality, which is OCTA angiography. So that is the latest advancement. So we can just avoid doing FFA in such patients. So angiography OCTA is a very good technique which can avoid invasive procedures in such patients who are very vulnerable to side effects of FFA. So that's good. And anybody have any questions can ask now. We will discuss about that.
Yes, ma'am. So we'll have a few questions in the Zoom, ma'am. So the first question you've answered for the question. For the sake of the YouTube participants, we'll once again we'll answer the question, ma'am. So do we see cilioretinal artery in all the patients?
Actually, it is seen in about 20 to 40% of the population. So not for all patients actually.
I request the participants to kindly post your questions if you have any in the Zoom account or in the YouTube live chat, before which we'll get back to the quiz question answers, ma'am. There's one question now. If problem like contraindications are there, so what has to be done?
Actually, if it is found already, then they'll speak to the consultant and they'll try for some other modality. But if the side effects are seen when the patient is undergoing the procedure, they will always have an emergency kit. So they have to have a very good setup of the emergencies, like how to tackle the cardiac arrest and all that. So definitely there will be a sister in charge for that. And if required, they will also have an attending physician, and they will always have an ICU support. So because as it deals with the blood related disorders, so the emergency related medicines should be there in place all the time. So we should not take risk of such very severe emergencies, which may be present in a very rare situation, but still we should be in a position to prepare for such emergencies as well.
Thank you, ma'am.
And if there are no questions, can Punitha summarize the findings? Punitha, someone whoever is attending the session can summarize the key findings of hypofluorescence and hyperfluorescence. In which cases you'll see hypo, and which cases you'll see hyper.
or
Anyone
you
can also
can
answer or
share the PowerPoint and discuss, Punitha.
Yeah, ma'am. One second, ma'am.
Yeah.
I'm
yeah,
sharing.
you can just summarize the findings, key findings of your presentation. Just in which cases you'll see hypo, which cases you'll see hyper. If you reiterate, it will be there.
Okay. Difluorescence is mainly caused by block fluorescence. So when there is any hemorrhages, exudates, or any glial tissue and retinal pigment, um, there we can see the hyperfluorescence. Then coming to vascular filling defects, when there is an emboli, atherosclerosis, vascular non-perfusion, and vascular occlusion. So if we see for the disease condition, the ischemic diabetic maculopathy reports the hyperfluorescence due to capillary non-perfusion, and central retinal vein occlusion that occurs with capillary non-perfusion. Then when you look for retinal artery occlusion, we can see hyperfluorescence due to blockage of background fluorescence by the retinal swelling. And for the hyperfluorescence, we can, in diabetic retinopathy, the scattered hyperfluorescence will be seen due to microaneurysms and leaking microaneurysms of central diffuse with a flower metal configuration. Then coming to leakage corresponding to the center of the exudate ring. Then coming to proliferative retinopathy, this appears due to leakage of disc vessel. Then branch retinal venous occlusion. It occurs due to capillary non-perfusion and with blockage of blood. Then in macular ischemia and proliferative sickle cell retinopathy.
Thank you for the summary. Do you know something called there is fundus autofluorescence?
I get to know here and there, but not that much.
Okay. Anyone know what is fundus autofluorescence? Because you should also know that concept, because as you are dealing with the fundus fluorescent angiography. Anyone, if you know the answer, you can answer in the meeting, or I'll just convey the same. Okay, let me tell you what is fundus autofluorescence. Fundus autofluorescence, the name itself suggests that there are certain cells in the retina which can fluoresce on its own. So without even injecting a dye, you will get to see the fluorescence of the retinal cells. So because of lipofuscin deposits. So that is a very good tool to find out whether any RP defects is present or not. So let me share the screen and show you the difference between the fundus autofluorescence image and fluorescent angiogram image. So that if you get to see any photo of any patients, you should be in a position to know which is the autofluorescence image and which is a real fluorescent angiogram image. So can I share the screen? If you stop sharing, I'll just share it.
Yes, ma'am, you can share the screen, ma'am.
Yeah, 1 minute. I just put in slideshow and then share the screen. Is my screen visible?
Yes, ma'am.
Okay. So if you see here, can you tell me which is FFA image in this slide out of the 4 images. Is it B, C, or E or F? Anyone can answer, not only the speaker.
Students, try answering.
I'm not
Yeah.
able to hear. Anyone is
Yeah, she was telling about telling to the students to
Okay.
respond. Yeah.
Okay.
Yeah, you can just guess. No, it is. There are 4 options. The answer is going to be one of the 4 only. So you can just type it. If it is wrong, nobody is going to ask you anything.
E, ma'am.
Can you be a little louder? What did you answer?
E. Picture
Yeah,
E.
that's correct. So, can you tell me the name of the other modalities as well?
So
What is C and what is F?
if you can't speak, you can even type it in the chat box. So if it's wrong, no problem. So of course, everybody is learning.
Okay, let me tell you, this B is actually infrared image. As you can see here, there is more of scattering of light which comes from the hole, which is the optic nerve. As there is no structure in this region, you are just seeing more amount of light, and the background is full of grayish in color. And if you see here, the second image, which is C, the disc is almost blackish in color, and also the vessels are filled with black color. So that means this is actually autofluorescence, Fundus autofluorescence, wherein the blood vessels have absorbed the either blue or green light, and it is shown as blackish region. And if you see, this is the real FFA image, wherein the arteries and veins are filled with fluorescent dye, and it is actually arteriovenous phase. As you can see here, both the arteries and veins are filled with dye, and this is actually the defect. I don't know, you want to guess the defect, or let me tell you what this condition is all about. Anyone? This is not a normal image actually. So all 4 correspond to a single disease. So anyone can guess what disease is it? What type of defect, whether it is hypofluorescence or hyperfluorescence. If you find out that, you'll get the answer for finding out the disease. Okay, let me tell you, this is actually a leak in the arteriovenous phase, and the last image is actually ICG image, that is indocyanine green angiography. As you have told that one of the limitations of FFA is you cannot see the choroidal circulation. So that is the reason why we have another modality, which is indocyanine green angiography, mainly for choroidal circulation. And you can see here, all the 4 images have something in common. The one, I think I'm just moving the mouse here, maybe you can see it very well. So this is actually, I'll just show with the pointer. So the one which is in the center, this is actually kind of a circular region which is elevated. And similarly, you can see the same thing in the autofluorescence image. And this is actually nothing but subretinal fluid, which is seen as an elevated region. And in FFA image, you can see something is leaking. So because of this leak, you can just see more amount of hyperfluorescence, and which is also seen in the late phase of your indocyanine green angiography. Actually, this is also called as ink blot appearance or smokestack appearance, which is commonly seen in central serous retinopathy. So because of defect in the retinal pigment epithelium, the fluid will reach the retinal structures, that is the space between the neurosensory retina and the retinal pigment epithelium, because of which you get leak, and that is seen as kind of increased fluorescence in the fundus fluorescent angiography. So this is how you have to differentiate it with different modalities. So I'll just repeat once more. So this is an infrared image wherein you will have more scattering of light in the disc region. So this is your flu, and you will not see much of blackish region of the blood vessels, and the background will be much of grayish in color. And if you see the autofluorescence image, the blood vessels, the disc, everywhere it will be black in color, and the background will be of light grayish, not as gray compared to the IR image. And this is actually a fundus fluorescent angiography image, wherein you can see the background vasculature of the retina very nicely. But in ICG, you will not be able to see the vasculature of the retina because you'll be seeing only the vasculature of the choroid. So if you have any doubts, you can ask me now. I'll just repeat it if anyone is not clear about whatever we have discussed so far. Any doubts?
I think there's a question in
Questions, yes, ma'am. There's a Zoom question, ma'am. How many fundus photos can be taken during FFA?
Okay, actually, it's not that number of photos doesn't matter, but the photographer will start clicking the images immediately the dye is injected, so that they will not miss anything. But we are more concentrated on the arterious phase, arteriovenous phase, then venous phase, and late phase. So as discussed by the presenter, it takes at least 1 to 2 seconds to reach the choroidal phase. So it will be initially blackish. Then they'll keep on taking the serial photograph of the retina. So the consultant will write which eye is very important. So that they'll concentrate. Say, for example, if right eye is more important, they'll start taking the right eye images first because they want the early images first for that condition. Because some conditions will require early images, some conditions will require late images. So that is why they'll just concentrate on that eye, which is very important, but they'll not stop taking photograph. So till 20 minutes, they'll keep on taking the photograph. So the late phase actually takes around 20 minutes. So beyond which you will not be able to take any photograph. Otherwise, you will not be able to see the fluorescent in the retina. So that's the answer to the next question.
Yes, ma'am. Thank you, ma'am. So that's the question in the YouTube. So how
Okay.
much time it will take the retina to completely get rid of the dye?
Yeah, that's what. After 20 to 30 minutes, you will not be able to take any photograph. So if patient has encountered any side effects within that time, so they will not redo the test. If they have vomiting in between, they'll just try to solve that issue and immediately they will start taking the photograph. So that's what people do in the clinic.
There's
And-
one more question in YouTube, ma'am.
Yeah.
So what is retinal staining in FFA? Retinal staining, ma'am. What is retinal staining?
I think she had the photograph. I don't have it. Can you just share 1 minute? Let me finish this and I answer. So this is another image which I have. So this is actually an IR image, and this both are actually fundus fluorescent angiography image. So this is actually arteriovenous phase, and this is the dye which is leaving the eye. So I just wanted to show the difference between different modalities because every investigation will have black and white in color. So let me stop sharing the image. Maybe she can share. She has a slide with which shows the fundus fluorescent image with the staining defect. Can you just share your slide so that it will be easy for
Yeah, ma'am, 1 second, ma'am.
related? Okay, you can see here the staining is because of more fluorescence. So could be because of any thing which causes blood vessel damage. And there are also other structures which will strain, such as optic nerve head and sclera. But with respect to the pathologies, all scars will have increased amount of fluorescence. So that is called actually staining, which you can see very well here in these images. And the one on the left-hand side is actually, it's a proliferative retinopathy, wherein you can see the venous beading. That is, it's kind of a beads. Can you just show with your mouse? The one is on the superiotemporal region. Left side of the image. Yes, you can see here, it's kind of a bead in a necklace. So some beads will be present, that is, it will compress the veins in particular regions. So there is this very particular sign of proliferative retinopathy. Yeah, that one, and the one which is on the down. The other, the V-shaped structure on the next opposite to it, little below it. The one which you showed, the other branch of that same vessel. That also has the other one, little down. Yes, no, not the same image is there actually. Just go to the same image. Yeah, little down. The V-shaped structure. Yes, correct. So that is also as venous bleeding. So hope I answered the question.
Thank you, ma'am. We have another question in YouTube, ma'am. How many degrees of retinal field should be seen while doing FFA?
Actually, there are different actually there are different instruments available. So the size which we have in a normal clinic can take up to 45 degrees. And we have the latest advanced technique, which is your Heidelberg retinal tomograph, which has approximately 102 degrees. So we have different degrees actually. We have 55-degree photograph and we have 102 degrees. So even the peripheral retina can be taken with the help of such advanced instruments. Or the other option is montage can also be done after the image is taken. So that's the reason why instead of taking only the central macular photograph, the technicians will also ask the patient to move in different directions, right, left, up, down, so that any peripheral disease or any capillary non-perfusion in the peripheral region will not be missed, because they take in all the different directions. So that's the reason why they take images for the whole 20 minutes. So they'll concentrate on the central region and they'll ask the patient to move on different directions for both the eyes. So, and then once 20 minutes is over, they'll take the base images.
Okay. So there is another question, ma'am, in the Zoom. Conditions can be assessed without FFA also. So why do we need to diagnose it with FFA? Some conditions can
be assessed without, that's what, not all conditions require FFA diagnosis. So whichever conditions require blood-related investigations, like in case of they suspect any leak, in case of CNVM or in case of CSR. So only those blood-related vascular conditions will require fundus fluorescein angiography, not all cases. So when, and especially peripheral diseases, peripheral vascular diseases require FFA, like diabetic retinopathy. If the neovascularization is present in the periphery, then we will miss the leakage in that point. So that is the reason why FFA is very important. And if the DR is present in the central region, OCTA will serve the purpose. But if it is there elsewhere in the retina, then it is difficult to catch the same in the OCTA. So that is why FFA is very much indicated, though we have advanced techniques.
Thank you, ma'am. We quickly go through the answers for the quiz topics today, ma'am. Yes, I request Meenakshi to kindly pitch in.
I guess we also have one more question. If the patient is not eligible for FFA, ma'am, what else procedure can assess instead of FFA?
As I discussed in the previous questions, so if the patient is not eligible for FFA, they'll go for other modalities like OCT and OCTA. So that is how they go for it, or just a general clinical examination will also serve the purpose. Nowadays, OCT has changed the treatment modality to a great extent. So that is the alternate to patients who are not eligible to undergo fundus fluorescein angiography.
We also have one more question. While doing the procedure, who actually will inject the dye, ma'am?
Actually, it is the sister. So the staff nurse will inject because they will know where to inject intravenously. So the trained nurse only will inject because they will also check the blood pressure level, and if the patient is allergic to any medicines, so that also has to be taken care of. And they will also take a note of what they took like 2 hours before, whether they had any lunch or a sandwich. So whatever they had at least 2 hours before, they'll make a note of it, because if they are not in fasting, they are prone to have vomiting immediately of the test or during the test stage.
Yeah, ma'am. Thank you so much, ma'am. We'll just quickly brush up the answers for quiz. Okay, first question is by the barrier filter, which light will pass by or which light is getting blocked? Usually the blue color lights will be blocked and the green yellow light is passed by. Second one, how long does the dye takes to reach the retina? It is just 10 to 12 seconds. So we start the procedure within 10 to 12 seconds. Then the last question is that why cilio-retinal artery is being stained up during choroidal phase. It is actually the branch of posterior ciliary circulation. That is why we see cilio-retinal artery getting stained up in choroidal phase. Other questions we have discussed in the forum. Over to Gomati.
Thank you, Meenakshi. Thank you so much, Ramya ma'am, for joining with us today.
Thank you. It's my pleasure to be moderator for this online session. Thanks for inviting me, Maheshwari ma'am, Gomati, Miss Gomati, and Miss Meenakshi.
Thank you, ma'am.
So you have, for each and everything, so with a lot of patience, and you explained it very clearly, and I hope this will be very useful for the students, and this will be in our library, so it will be online and anybody in the world can open it and access it at any time. So this is going to be our great asset. This video is going to be our great asset, and I would like to thank you. And yeah, before we close, I would like to just give one information about our recent achievement from our college. So there is a competition held in Ramya Institute of Management, which is in Bangalore. So they conducted a contest. It was an innovation contest called Vritti 2023. So in that contest, Ms. Gomati, she presented the innovation of a semi-automated prism bar, and she won the first prize, and she got the cash award of ₹10,000. So, it was the student project. Further, it was taken up, a lot of efforts she has taken up, and she presented it, and she took effort of applying it and presenting it. So I would like to congratulate Gomati and Ms. Bhavani for their efforts. So I hope many more achievements will be coming on your way. Thank you once again, Ramya, for your expertise and sharing your knowledge, and thank you for your time with us.
Thank you. Yeah. Thank you so much.
Thank you, Ramya ma'am. Yes, thank you so much, Ramya ma'am. And I would like to thank Maheshwari ma'am for guiding us, because ma'am has given so much of tips before we participated in the competition. Thank you so much, Mahi ma'am.
Okay.
Thank you so much. Thank you, Zoom audience, as well as the YouTube audiences. If you got any doubt while you're watching the session, kindly post your questions in the comment box. We'll get back to you with the answers. To know about more happenings at Dr. Agarwal's Institute of Optometry, kindly do follow our Instagram page and Facebook page. We'll meet you all in the next episode. If you like this video, give a thumbs up and share with your friends, and do subscribe to our YouTube channel. Thank you all. Meet you all next week. Bye-bye.
Bye.
Bye-bye. Bye.
Thank you.